in improving the quality of care at that point?
Some yes, and some are not focused on that. So depends
Okay.
on the organization.
Let's hear it for our panel.
Can't thank you enough, Kevin, for this. I'd also like to thank John, Paul, George, and Ringo for doing a very nice job on the QHINs. Right. You guys decide. Two other points, and sorry, we're going to plow through because that's the best we could do. If you need a bio break, that's great. Do not go out there and eat lunch now. Okay, that comes after. It is set up. One is, unfortunately, Virginia, there's not going to be that singular, vehicle in the near future that helps. Okay, no, not for the foreseeable future, not this year or next. But there are a lot of different tools, a lot of different capabilities, utilities that we're going to have to use to go from a thread of connectivity that we have today to the quilt. Question will be which ones for whom. And it does sort of remind me of marketing, believe it or not, and market segmentation at Xerox, understanding different scenarios, and we'll have to figure out how to do that. But now quickly, we want to get to the next panel. And I would really, really appreciate if Tom would come on up. So Tom Hallisey, Digital Health Strategy Director of HIMSS Health Association in New York. He spent his entire career guiding healthcare organizations to improve operations and care quality, effective use of IT, including being a CIO at Cayuga Medical Center in Ithaca. He's currently Haney's head of digital health strategy, a trustee on the board of Albany Med Health System, an adjunct professor of SUNY Downstate. Wow. Formulates and executes Haney's state and federal HIT regulatory and legislative agenda and provides education and collaboration to New York health systems. A lot of people rely on Tom. His work includes guiding statewide collaborative efforts to improve care through tech in areas such as virtual telehealth, cyber, and clinical informatics. He received multiple degrees from University of Connecticut, where I'm sure he had the opportunity to see many amazing basketball games. Unfortunately, many were victories over the #1 college sports team in New York State, guys, the Syracuse Orangemen, right? Okay. And Tom, take it away.
Plenty enough. Too much. Done? Yeah.
So thank you, Al and Tony, Al, for doing all the work, getting all this up, inviting me, Tony, all the efforts and the food, which we promised not to keep you too long from. So just a couple quick remarks. We certainly heard this morning that any interoperability issues aren't from lack of effort. In fact, they aren't from lack of options either. We've got lots of options. And what we heard a little bit from Virginia was maybe too many options, maybe too much complication. It's confusing. There's a lot out there. And in our last panel, what we really want to look at is where the rubber meets the road, where the magic happens. Do we get the value? And the last panel began to note that, but we heard a lot of tech, we heard a lot of policy, and moving data around alone doesn't accomplish anything, at least not until our AI overlords take over and run the forth. But at the moment, we still have to get that data down to the actual clinicians and see that value. And is it improving care? And so I'm honored to moderate the panel of providers and from provider groups where we'll take a look at that. So with me today, I have Lisa Nelson, who is the Associate Vice President and Chief Application Officer, almost said academic on my brain, at the University of Rochester Medical Center, and is a pharmacist by trade, and brings that knowledge to her role. I also have Patty Cortus with me today, who is the Associate Chief Medical Information Officer at Mount Sinai, and also a physician assistant, still practicing, and past president of the New York State Society of PAs. Notice they're all clinicians except me. because I also have with us today Dr. John Travis Gossi from Weill Medicine, where he is the Associate Chief Medical Information Officer and also still practicing internal medicine. Just keep standing. So, no, I'm joking, Tony. I'm fine. I'm still much younger than I look. No, I wish. So I think to start us off, we really we want to hear from the provider perspective. Where do we stand now? How are we using this? What value we're getting? So I'll leave it that wide open and we'll jump right into that. Lisa, if we could start with you and University of Rochester.
Oh, see, I thought I was last on the list, so I'd be last in the
well,
question, but that's okay. So Tom and I work together, our partner on the Haney's EHR group, and so we've been talking a lot about this. So thank you for those of you who participate in that. There's too much data. I mean, again, as a practicing or as a pharmacist and someone who's now in charge of the EHR, I want as much data as possible. I think data is good. We're doing some stuff with AI, but I will say, besides pipes, I actually see it as a multi-lane highway. So I was driving in from New Jersey today, not very different highways than we have in upstate New York. But we're going to need to connect. You know, we're in Rochester, we're very fortunate that the major health systems are all on Epic. So, you know, one might be inclined to say, let's just exchange with each other. But we also have a very, very engaged Rio and HIE, and then we're exchanging all over the place. The thing that bothers me is that we have all this information coming into the EHR, and what I hear from clinicians is it's just too much, and it gets to be noise. There's duplicates, and it's not all helpful. And so, how do we, now start powering to use AI to make sure that the right information shows up in the workflow at the right time for the person who needs to make the decision? Because just putting it on the health systems or the people who are with the setup to quote make the decision, I don't think is where we're going to get to where we need to be. So we have a lot of data and a lot of cleanup to do.
Absolutely. Thank you. And Patty?
What was the question?
Really, what's the current state? What are you using? Is it bringing value?
I mean, it's messy. It's very messy. And, that's coming from a system where we tried very much. I think Paul mentioned, the frankly lowest paid people are really left with a lot of responsibility. And that's unfortunate. We actually at Mount Sinai a few years ago, because we realized, why is it that we can't really take care of our patients with the data that we should know, right? Patients don't have it. And only because we're moving to this value-based care and moving away from fee-for-service, we started to pay attention, and we realized, oh, they're not consenting patients, so therefore we don't have their data. And no one knows this stuff, including providers. And that may have been 10 years ago, 8 years ago, 5 years ago, but still today. So yeah, providers, I mean, I talk to them all the time. I am too. Sometimes I can't even tell where something comes from. And I should, but we don't make it easy. So big word, see, you have to untangle it.
I can remember being in a conference, like an internal medicine meeting at Cornell, and someone said, "What is this information in Epic? I don't want it." It was when we went live with RX Hub, and it was just fill history and the patient's medications. That was kind of like the first time in which actual external data was available in the chart, like kind of seamlessly there. And she's like, "Don't ever send this to me again." But anyway, it's gotten better. I do agree it's a little messy, but I actually, I've been doing Epic stuff for 20 years now. I've seen how far we've come, and I see how far we can go. I'm hopeful that some of the technologies that are coming down the pike can help us ingest the data a little bit better. I was actually going to make a joke about how it's nice to talk about something other than AI, but it seems to crop up in every conversation that we have. But But that said, I think we've actually done a better job of coalescing the data, at least in Epic, and like I think we're all Epic folks. In which like at the very beginning we segregated care everywhere in its own tab. Providers had to go to it, and that was because we all had the mistaken notion that we want it to be walled off. We want to know that it's there, but we don't want to be able to. We don't want to see it unless we have to do it, unless we want to. But now we've actually integrated like outside encounters into the in Epic. There's something called chart review. There's an encounters tab. Oh, you were seen at Mount Sinai 2 days ago. Wait a second. Why didn't you mention that to me? Like, how'd you know? And sometimes people get a little freaked out, and I get that. But it actually is helping us concatenate the data in a more seamless way. It's the way we think. It's the way we've consumed the data. We're doing that for radiology, for labs, that kind of thing. I think that's all a step in the right direction. If you expect the doctor to do a search to go to someplace else, they won't. If you slide it into where they're normally consuming the data, it works out better. But we are now getting like the it's just too much data. Previously, I would know that the patient, saw the cardiologist, that kind of thing. And they'd tell me if they saw someone else, but that was kind of the extent of it. Now we're actually really showing it to like our providers, and some people love it and some people hate it. It's also interesting to see the residents. Like after this, I'm going to go teach the residents. They're the folks that actually are the ones that, like, let's face it, take care of the patients in house, and they're the ones who actually are the persons who really are consuming this data, and they've come a long way. And it's actually very impressive to see how well they do with it. So I'm hopeful that the digital natives, like the folks that we're also doing downtime drills. And like the other day, someone's like, what's a paper script? I'm like, oh, bless you. And so like, we've kind of come full circle in which like the people that used to know paper are now the ones that are now in the minority, and the people that have never seen a patient without an EMR are now becoming like the dominant people in the community. And it's just interesting to see how that's coming about.
Yeah, and those expectations are higher than they've ever been, of expecting not just the way that we're all consumers and, we can schedule a flight on our phone. We should schedule a flight. And the expectations of the younger providers and nurses are really raising that bar, and they're asking good questions.
Absolutely. And the patients as well, as we've heard a little bit about. We're all consumers, including the clinician here, of this data. Dr. Gassi, in particular, I think you have some bit of numbers on, if you could tell us, not the detailed numbers, but where the data is being ingested from.
Okay.
So just to get a feel for the use.
I'm glad I looked at our interoperability dashboard this morning. So last month we sent out 3.5 million records. We received 2.5 million records. About 80% of the ER visits and inpatient visits, someone actually looked at the external data. Now, in terms of actually reconciling the data into the chart, like that's where they bring in the meds and bring in the allergies and bring in the problems. That was about 20% to 30%, depending upon the area. But hey, not bad. What people also find fascinating is that our number one trading partner aren't other Epic institutions. They're actually external. So we love Care Quality, Health, like all the other networks. We actually do a lot of volume with them. And so it's actually impressive to see that greater than 50% of our volume is not within Epic. Now, 10 years ago, that was the exact opposite. But things have evolved where like the other networks are now bringing in a lot of volume for us, and that's amazing to see.
Anybody else have any thoughts on that?
We actually had a fun little project a couple of years ago with and there was a lot of, I don't want to say maybe around reconciling, auto reconciling, right? And you're a pharmacist, so I know that. But everyone wants it easy, right? And it was literally having to be auto reconciling might sound easy, but it's actually very. So this is the opposite of AI. You need a person with some judgment to say, yes, this makes sense. Yes, I'm going to reconcile. And now it's going to be. So as far as we get to how many external sources of data come in, still need that kind of balance.
Yeah, I mean, we did it around COVID. I mean, we brought in COVID vaccines, but that was actually a really eye-opening experience, at
Yes.
least for us, in which in New York, there's a lot of people with like the first letter, the first name, and then the last name and the birth date. Like the city's CAR, like I love them. I'm not throwing the youth the bus, but their matching is a little leakier than what we're accustomed to. And so we had a lot of people that would show up to our mass vaccination sites and we'd be like, well, you got your vaccine last week. The hell I did, we're like, well, it says here that you got on your right arm from that, like, it wasn't that Amy Wang, it was another Amy Wang, who happened to be, same birth date, same everything. So they matched, they sit in, and this is at the height of COVID, in which we're trying our best to do our do mass vaccinations. And so we brought into the system, but that really exposed what can happen. And this thankfully is lower stakes because the patient can actually tell us that this is wrong and we could correct it. But it just exposed like how leaky some of the matching algorithms out there are.
What it exposed for us was how we weren't because of the consent issue.
Of patients over 18 needed to consent to share vaccine data.
Even in a public health.
Yes.
And let's just face it, the federal government doesn't do us a great job when they name these vaccines, right? This year, if any of you are paying attention, the flu vaccine, it goes from monovalent to trivalent to quadrivalent, depending on, and they don't all match, even though they are appropriate for the right year. And God forbid that somebody thinks that they're supposed to only give half of a quadrivalent versus, I have actually had that call in my role as an IT person. So again, I think, poor Tom has heard me kind of pontificate about how the state immunization registry could probably help us with some of this, but we won't go there for now. But I do think, right, auto reconciliation, while it seems like a great idea around a boardroom, and especially for people who are complaining, with less clicks, you only have to give somebody the wrong vaccine because of how it came across or the wrong patient. And then all of a sudden it's a lot of cleanup. And if any of us who've ever had to clean up our allergy records or anything in the EHR, that manual cleanup is very painful because our great colleagues on the interface side can't always just clean up. It's very hard to clean up data on patients, real patients, like patients in the same, once they have a record. I say that all the time. It's easy when you start and go live with Epic, but once you're actually actively taking care of patients, we don't get to do a Control-Alt-Delete and wipe the record and start again. So it becomes a little bit of a challenge.
Yeah, we heard that a little bit in the last group, that check your data, check your own data. And we know that's an issue. And I like the way he put that front desk person. But even when it's, a nurse that's doing that, their primary focus is that immediate care and not the data governance that then has to come into play. And all of you have to run to get this in place. I wanted to follow up a little. Everybody, I think, mentioned feedback from the clinician themselves and what they know or what they understand. And I know in my MHA class that I teach, there are a lot of physicians. I don't see Todd here, but Todd and Harold have helped and talked to interop to my class. And we get a lot of feedback with, I work at, and I won't name any of your institutions. I didn't know any of this happens. So just a question of what level of education you think they should have, or do they have? And I see some grins, but just some ideas on what you think there.
Well, we try our best. But I'm a physician as well. And so like I did my annual hospital training. I get assigned it twice. I have a Cornell account and an NYP account, so I'm considered two doctors. Yeah, anyway.
You gotta merge your account.
Yeah, it's fine, it's fine. But I mean, but like, I've got all that. So I've got that. And then I've got like, there's a mandate for pain assessments and pain management and blah, blah, blah. And you add it all together. And it's hard because you're also trying to see patients. And but my goal is just to nudge folks to kind of like let them know that it's different, let them know it's available, put it into their workflow, make the right thing easy, make the wrong thing difficult, and try your best, not necessarily to get in their way. It's otherwise, if people say like, that's a training point, if there's a lot of training points, then your intervention is not going to do well. You really need to make it as simple as using your phone. Otherwise, it's not possible to get people to do it at scale.
That's a
We-
great point.
And just that, so we actually spent considerable amount of money training, again, our front desk staff, but also our clinicians around what interoperability is, but we didn't call it that because it's too big of a word. Just like, hey, you want to see data on your patients, but also your patients are going to come and ask you questions. You should probably know the answers. And again, this wasn't necessarily because any clinician asked us. It was back when we needed to exchange data and care coordinate better. And, we were moving, it was the district days. Okay, I don't want to say that word too much, but yes, it was during district. A lot of us have scars and pains, and that's why I don't like to mention it. But the point is, it was good, right? Because it made us really look at why aren't we doing better, right? And all of these targets that the state set. And when we looked under the covers, again, at least at Mount Sinai and our 186 partners, we said, oh, we have 52 different EMRs. There's just no way that we're going to be able to know what is going on with the patient. And we're responsible for all of that. So we embarked on education. And we created videos. We created, a website on our internet. And we still have it. It's a little outdated, but that actually moved the needle for us. And it has been really the backbone for a lot of the work that we are now doing. That's okay. Everyone forgets how we started, but we're a lot better. That's one thing. I want to shout out a little bit. I'm not going to call their name, but we recently went live with something that, we don't always get good calls from clinicians. It's always like over there behind the curtain. But we actually just went live with an Epic with a little widget. I'll call it a widget. It's like saying, I know you're going to be jealous. Oh, you might even have it too. But it's like saying, what is the thing that we say in IT? Please don't say it's a glitch. No. Glitch happens in the matrix, right? Anyway, so it's a little widget within Epic in chart review that you can actually go out into an HIE's portal and see social determinants of health data. This is amazing, but what actually, and we don't have it, we don't have a lot of data yet because it's still just beginning, but we're trying to get all the information that we can about patients. But what came with it, and I was like pleasantly surprised, was that access to the PMP. One click. That does not happen. If you're a provider, that does not happen. It's like
And
you always count.
That was access to the PDMP, the iStop.
yes,
correct.
the
But,
iStop.
but that's because your HIE has set that up.
Yes.
That's not because, so for those of us whose HIE has not set that up. Right, so that's a great example of how everyone along the way needs to understand the data back and forth and be talking about that because, right, that would be a huge win. When I brought it back, they're like, oh, that's on our list way at the bottom.
Well,
So
it took us
maybe-
almost 2 years.
maybe
but-
Al and I'll have to kind of push but yeah, no, I think that's a great example of and when it works great and it's seamless, the wow moment.
Yeah, no, it's a great carrot to get people to use it. The person who implemented that at our place is sitting in here. So yay, thanks, Karen.
So,
But anyway, yeah, when providers, when there's a carrot for them to actually our adoption of that widget, we can call it concise.
All right, fine.
Their adoption of that was okay, but now there's another inducement for them to actually go there and explore it, and they're using it more because it takes away another burden in which they previously you have to log in once a day, but then it'll do the query for you. So oh, I can start going there, and so it's an inducement for them to go to that part because there's more of a reward than just data. It actually makes part of their lives easier.
And just to be clear, this is a Fire API app linked into the EHR that goes out to the New York State iStop PDMP to do the drug checking that's required for an order. So it's a great example of interoperability of, as we heard earlier, finally moving towards Fire. And so it's a tiny example really, but it's always the little things that they love the most.
It's the little things. I mean, when we presented it and we went to a lot of the different councils and we did a road show, because that's what you have to do so people know that it's there. You can't just send out a tip sheet, even though we still make tip sheets. Okay, that joke landed poorly, but we still make tip sheets. There's still the question of, yes, but what about the rest? The patient's travel. It's like, oh my God, you're never, and that's fine, right? We need to get continuously pushed by our providers, right? Because, we're here to serve the providers to take care of the patients, right?
So when we talk about education, we really tied it into opening up our e-check-in and allowing patients. So we have about 30% of people who are checking in on their phones, and really trying to say that you are a partner in your own data. And getting people very comfortable with the social determinants of health questions that we are asking to everybody in all facets. So not ambulatory, ED, all inpatient care, but that it's a partnership and you're responsible as the patient, as that, other person kind of monitoring that care. And if you see something, say something. Now, I will say people are very happy to tell you when it's wrong, which is fine. And we want them to be able to say that, because that's how we figure out that there's things that are broken, or that, there's MPI loads that are, but it was around that. And then when we started engaging the patients and the residents were also a big piece of this, all of a sudden people were like, tell me more. And kind of, using some of our M&M and some of our more academic conferences to kind of bring in some interoperability good catches where it's actually made a difference in patient outcome, but also some near misses. So we tried to kind of package it that way.
I do want to go back to one other thing, because, more data isn't always good. And
I think we've moved the needle on this as well, where a lot of providers, physicians, especially, either within our own network of hospitals and practices, would say, you're making my accountability higher, my liability higher, because what am I supposed to do knowing that the patient was admitted to an ED or is in jail? What am I supposed to do with that, right? So we have gone from too much data, I don't want to know, please don't tell me, to options like, okay, then subscribe to them, right? So allow the subscription. We have a menu. Or, okay, if you don't want to know, that's fine. You don't have to know, but at least the option is there. We have moved. I haven't heard it as much recently of, please just don't tell me.
And I don't have a small hospital up here, but I wish I did, because I would give a shout out to the HIEs across the state that look to add some of those services, because as larger health systems, you have that menu, you create that, you ingest all of this and decide, as Travis mentioned, how they subscribe to it, what given clinician wants to pull in. That doesn't all come naturally ready to roll.
It's not lost on us that, we are lucky that we are funded in some ways, but we're never funded enough. We never have the right amount of resources for what we should do, compared to our size.
So to go back to, and by the way, anyone online or here, please feel free to ask questions instead of having me ask them all. But I just wanted to bring us back to what we heard all morning. TEFCA, mostly TEFCA, but we heard from the QHINs, the HIEs, QEs, whatever acronyms we want to throw around. So what did you hear that you think will add value? Or what do you think was missed that maybe we should be doing? I'll throw that out to anyone who.
I'm on the board of the eHealth Exchange. I'm on the coordinating committee. So
Putting that aside, I think we all need to do TEFCA. I think that it's going to be very confusing, more than it is now. Forget about providers, but even just leaders and decision makers. We need to educate on, sign up for all the QHINs if you can, right? But, don't choose one over the other when you don't understand it quite yet, or maybe sign up for none until you understand it more. But, because each one will, as they said, will bring a different flavor. And we need to kind of move together, because That's going to be what's going to make the difference.
I think that was my multi-lane highway.
Yes.
That's kind of what we're doing. We're signing up for, some is good, more is better. And then obviously partnering with Epic. Because again, I think we at least, we do a ton of exchange through Epic because of where we are in the state and the fact that, we have a lot of people referring to us. And that is actually the way our providers would rather get it because they feel like that, bringing in all that information from another Epic visit that lands properly just makes their practices easier. But, until it kind of sorts itself out, I guess I don't want to exclude anyone at the party. You mentioned something else about doing drills, and I will say to everyone here, I do think there's a huge benefit to our HIEs and you all have our data that if we have an issue and we are down, how can we partner better with you giving us and partnering with us in almost like what we did in COVID in a 72-hour, let's get everyone signed up and get that data back into our paper charts because that's how we're going to be able to take care of patients as we as IT people bring up our systems. And so I do think that there is a missed opportunity maybe of quantifying that and standardizing that we all could use as we talk about some of these new regulations with cyber attacks, but just the fact that that's something we deal with, the cybersecurity and cyber risk every single day.
And actually, that reminded me of Virginia. You want one pipe? That scares me because we need to diversify. But there's a balance, right? So you don't want 600 pipes, but you don't want one or two. And because for us, what happened to us recently, I won't name them, but they might be a big SureScripts company. They actually gave us very little notification that we weren't going to be able to use them. Like, what do you mean? Please give us more time, right? So again, you don't want to put all your eggs in one basket.
Travis, any thoughts on the good or
Well,
bad today?
Well, no, what I'm looking forward to, so I'm like, I don't take a lot of new patients. I don't have a lot of bandwidth, but I have a new person who's coming to see me next week. She had a stroke and is going to move in with family here, needs like some care. And I got the paper records. I couldn't pull them down from the hospital that she was at. And so I'm looking forward to greasing the wheels of like, finding those.
That means you had a fax machine.
Yep. Everyone talks about like there's the fax and there's all these things. I think it's a cockroach. I don't know when it's ever going to actually fully die.
I agree.
But yeah, there's still blind spots, and I'm happy. I'll be happy when like if I never have to have another paper chart faxed over to me, that'll be like I thought I escaped it, but
What about e-fax? Does that count?
yeah, well,
And if
yeah.
you think it's confusing to us, imagine the patient who's heard all of these things that are going on. Imagine if they heard this whole morning and then yet there was a fax. How could that possibly be? And I see a question.
So, interoperability, and I'm probably one of the older ones in the house, but I've been at this for a while, and my interest always has been the patient in terms of benefit to the patient, and I think we planned this, and I think it's a great event. Obviously, yeah, I put my 2 cents in. All that is good, and I heard everyone talk about the providers and the data and who has it and who doesn't has it. And my bottom line is, as your organization, are you measuring the impact that what you are doing, and when I say you, is not in general, all these things that we are doing, are you measuring the impact that is having on patient outcome in small numbers, big numbers, or you're not? You may not be able to answer that. If you are, is that part of your performance improvement, the gadget widget? Now that you have that and you see that as a wonderful thing, do you tie that into how it's benefiting the patient outcome? The providers are probably going to be happy, but how does that specifically benefit a patient, a day in the life of a patient?
Can I take that?
Great
So I love that question. So a few things that we've done at Mount Sinai. So because our patients see the notes and the results sometimes even faster than the providers, we've actually taken a huge initiative over a year now. We call it the FAIR Project, where we look at stigmatizing words, and sensitive words and never words and things that can hurt the patient. So that is a huge focus. It's led by our health equity partners, and we have health equity in our technology group as well. So that's one aspect, right? So as we're putting data out there, it has an impact. Sometimes it's qualitative, can't always measure it. Or you might want to measure it in patient complaints, but you don't really want to do that. You don't want to wait for the complaint to measure. The other thing that we've done recently at Mount Sinai is we've applied for a grant from AHRQ for patient-centered data using some of these tools, some of the QHIN tools. Somebody asked, well, what about the patients? How do they have access to whatever TEFCA brings? Well, it's in the research side right now, I think. I don't think any of us have figured it out, but at least we're asking the questions, and we're going to put some time and effort to learn that. Because, yeah, the patients, we all talk about data, but it's the patient's data. I know we say that all the time, but do we really believe it? It's the patient's data, right? So there's been a lot of controversy also with third-party apps and, going through the patient who knows the least and understands the least. We're all patients, but we're not typical patients, I don't think, right? So when you have that kind of vulnerability, I don't want to get into controversies, but I do agree with some of the things that have been done there.
I have another question over here. One over there and one online.
Hi, hello. My question is, what do you think about organizational's authorization policies and how they affect clinicians' ability to receive the information they want from outside sources? Basically, opt-in versus opt-out workflows for interoperability, and how can we ease some of those restrictions potentially with our compliance and HIM groups? New York being one of the most restrictive states in the country when it comes to this kind of thing.
So yeah, the consent process is very challenging. I think we talked about, I'm looking at, our colleague in the back there about, just having a universal, especially as we all become more and more connected and our patients are moving. I think a universal consent would solve a lot of those problems. Because I think the patients are very confused when they have to sign the same form, and then they start asking questions about, well, why am I doing this? What does this mean? I already signed this before, and it's awkward for us. It's confusing, right? We're all semi-confused, and then trying to say it in a patient-friendly language in a way that doesn't sound like, we're selling your data. I also think, organizationally, change healthcare, trying to explain to people, even within our own organization, I didn't realize we were sending that to change. I'm like, I didn't either, because we signed the BAA, we didn't even need a BAA. I think as we're starting to look at our structure and who we're actually sharing data with, not just a one time when we're buying the application, but all the way through and on an ongoing basis, we're starting to realize, right, we have data, not only what we're sending out and what the patients agreed to, but then once it's out there, who else is seeing it? And that we actually are losing control of our patients' data in a way that, and it's valuable, and people are paying lots of money for our patients' data. So obviously, that to me says, okay, then we need to go back and relook at that, because there's a value there.
But I love that question also, because the providers are confused. They think that we're saying you can't see that data about your patient. It's not us, right? I think we're still one of only 7 states that are opt-in, right? We're shouldn't be doing it this way. And David knows that. He's trying.
Yeah, and just to be clear, David and his team and some of us on different committees are looking to change that.
Yeah,
with
and,
the HIs.
and we need to. But that, again, how do we educate our providers that it's really because the patient
believe the one back here was just asked up front.
Oh, okay. So I think I first had a question over here.
I agree with you, your opening statement about how there's too much data, and I work in data, so, but I still feel that way. But if we were to refer to it as information that helps the patient rather than patient's data, we would think totally differently about it, right? But it's not all information. And so I think that behind the interop problem, behind the data collection and aggregation problem, lies the data usability problem, which is really where we're at now. And I was thinking about what you were talking, you spent at least 10 minutes talking very positively about something that no one used the word for, which is user experience. Yeah. User experience in the systems that providers use. And then you said, those projects are always at the bottom of the priority list. I think that that is going to be way more important than AI in the next few years in ensuring that providers can actually make use of the data. I wonder what you think.
Excellently said. You said it great. We can end now, Tom, and all these poor people can go eat. I mean, I think that's a really interesting way of looking at it, and it's right. It's spot on.
Yeah, and so like one of the things we have our upgrade Saturday. I don't know if you guys do. Oh
Yes, look at that. What a
Typically
coincidence.
on daylight savings changes, it's a perfect time to do your updates. Anyway, one of the things we're doing, we're actually trying to simplify Epic. So we're collapsing the plan and wrap up tab and the ambulatory visit navigators and stuff like that, in which we found that people don't like clicking around. We were like, okay, we're not going to make them scroll. We'll make them click. And now we're finding that they don't like to scroll. But so anyway, we're also doing something where the system looks at how you're using it. And if you don't interact with that part of okay, I do my smoking history, not in the vital section. I do it in the history section. So eventually the vital section will just have the stuff that I interact with. And the stuff that I don't, I can still, if I want it, I can still push a button, it'll show up. But it's going to simplify it a little bit so that I don't have as much cognitive load when I'm interacting with it. So the user experience is something that's important. I think that we're trying. It's just one man's treasure is another woman's junk, or what have you. And so you try to take something away and how dare you? And but I never look at that. So I think every upgrade is my time to move the cheese on everyone. So we'll see.
And we have gone from a triple aim to a quadruple aim with
Quintuple. It just went up to 5.
Oh.
Health equity.
Health equity.
But of course. But the fourth item there was, of course, that clinician, and not to upset Travis and bring the AI into it, but I think AI will be a part of it, and certainly is early on.
Yeah, but last night, I mean, how many? I don't know. Did anyone see the whisper? The concerns about the whisper technology, writing notes and how it hallucinates?
From AP News.
Yeah, that was my evening. Okay, we have a very good relationship among our ACMIOs in the consortium, and that's what we were texting about last night. Oh my gosh, thank God we didn't go live with that one. And but I mean, these are the things that keep us up. We're okay, this is great, we're excited, and then you're you read some of these, it's one in 1,000. But wow, that's actually more prevalent than I thought. And
we talk a lot about that in our EMR group, but that's also why we're starting a provider AI group to really discuss locally, because there's a lot of systems already using that tech, and we need to discuss that.
And it's a cool party trick. I mean, let's face it. But then well, anyway, I can talk about our evaluations of them.
Yeah.
But some of them are it looks really cool until you actually try to use it, and then it's oh, this isn't exactly what I thought it was going to be.
So I think I'm told we're out of time. I see a lot of questions, so I know I'll be around. Hopefully others will for lunch. Maybe you can ask questions while we're chewing.
Feel free to send us questions.
So thank you all on the panel. Thanks, Al.
Turn on the mic.
Al, turn on your mic.
A little bit of wrap up and some thank yous. only minutes. So, first of all, we heard today, there is no silver bullet yet. Virginia tasks us to get there, and we're all going to try. Reality is, it's going to have to be viewed differently by every group and every type of organization. We want to go from threads of connectivity to a quilt. Who needs a quilt? Well, providers need a quilt. And today is largely health systems. We could probably do a mini version of this for FQHCs. Who here works a lot with FQHCs? Anybody?
How many did they?
Yeah. Or nursing homes, or specialists, or public health, as was discussed today. All have their own view of the challenges and the opportunities here. Public health, a lot of what David told us about is going to be used by New York State today, but there's also community public health, and the 1115 waiver is a big part of that. Pharma, devices, AI solutions, and payers. Each of them has different use cases. We heard some of them today, whether it's point of care, transition of care, pop health, et cetera. We're not going through this, but it's thinking through from each of those providers, each of those types of organizations, what do they need interoperability for? In particular in public health, whether it be the community or the state. There's a whole plethora of tools that are available today, and you need to understand the capabilities that your organization or any of these organizations has in place. Like Jordan DeMarco, you know, he really delivered on systems structured thinking. It has to start with, what do you have in place? What are your requirements? And how are you going to get from here to there? You have a whole bunch of tools to choose from, and there'll probably be more that come around. Each of the QHINs is different. That was an excellent discussion. I learned, everyone learned. I hope everyone learned something today. So what kind of quilt are you going to design to help you accomplish your needs? It'll take a while, but I hope that we'll be in the continue New York State's efforts to help us do so and provide more tools for us. So I want to thank everyone for participating. It's a long day. I know you're hungry. We do have lunch, but Tony's got some housekeeping to thank us up with, and thank you very much.
Thank you, Al. Appreciate it. Real quick, Dr. Prasad, would you stand up, please? I would like to point out to everybody, Dr. Prasad's idea was to do this today. He came to our committee, our programming committee, put it out there. I'd like to have a nice little round of applause for him. He's also part of the organization called HEC, the Health Executives Club in New York. Marcia and Dennis Conway are part of that group. They help us be able to fill the room, which is terrific. And last but not least, we can put up the sponsor slide.
Yeah.
Oh, yeah, we'll get. What I want to do is, everybody, before you leave, go out there and hug one of those sponsors, because they gave us enough money to get all that good food here. Okay. And thank Microsoft for offering their facility to us. Now, if everybody knows my motto, it's no eating, no meeting. So we have that in a couple of minutes. And then last but not least, we're always looking for new volunteers to join our New York HIMSS group. There are plenty of opportunities. Like Dr. Prasad came to one of our meetings. We listen to good ideas and we expand upon them, and then we go out to our community. And I thank folks like Tom, folks like Al, folks like Virginia, who then extended themselves to be able to put it out there. And also our nursing committee, where when we mentioned to them, Olga, please stand up. There we go. We got everybody involved and we put it out there on social media. And anybody who didn't sign up, they're the losers. We're all the winners here today. There we go.
Not to join HIMSS state chapter, $39. If you're a national member, it comes with it. For $39, you would have saved $25 today. So please join.
Okay.
Like that.
So again, we have food outside. Continue your networking. I'm sure everybody's got a few questions of some of the other speakers that are still hanging around. I'd also like to give a big thank you to all of our moderators and panelists. Great job to all of them. Don't want to have to repeat everybody's name because I'll probably screw it up anyway. So there we go. Everybody have a great day. Oh, 1 second. Put these slide up. I want to tell you something that we do each year, at least one of our events. We take the extra money that's why we charge everybody a couple of bucks. And we make a donation out to a 501c3 healthcare organization. This year, there it is. And I think David Fripkin, we're trying to get him on the line. He'll just say a couple of words. But as you can see, Blaisdell Children's Hospital cares for patients with emerging medical concerns, okay? Everything from tuberculosis and polio in the early years, emerging medical disorders today. They're a great organization, and they help those that are in need. From what I understand, they're a predominant Medicaid hospital. Okay, so every dollar that they can get provides care to someone who is in need. And guess what? We're helping. And all of you folks out here today help. And I want to say thank you to every single one of you folks today, because that money is going to go to good use and provide somebody, maybe not to the individual that needs the care, but maybe to their family, to know that there are people out there that care and want to be able to help them.
So it's open.
All right. Okay.
He's on. David, you
Hi,
got the
I'm
floor. Give us a.
Thank you. I'm David Friedkin. I'm the administrator of the long-term care unit at Blaisdell Children's Hospital. The leadership wants to thank HIMSS and the HEC for the donation that they're giving to the organization. The children are the benefactors of these money that you're giving us, and will benefit from your generosity. Thank you so much for all you're doing for us.
Thank you, David. It's a pleasure on our end here, everybody in the room. Put the money to good use, help somebody out, and hopefully one day you and I will get a chance to shake hands. Okay?
Definitely. Thank you so much.
Have a good day. Everybody go enjoy some lunch. Thank you. Go.